Thank you, Dr. Kent. Good evening, everyone. I'm honored to be here with you today. So as you all know, skin conditions are a common
يا
concern in
حبيبي
place populations, and our skin responds directly to the environment, the humidity, the crowded conditions, and the stress. They all worsen common dermatosis. But another major problem is the poor hygiene. So a lot of our displaced patients report lacking water, and they're only able to shower twice a week. So I'll be starting with infectious cases spreading amongst displaced people. This presentation will cover parasitic infections as well as bacterial, viral, and fungal dermatosis. But I will also mention few inflammatory skin conditions that can flare during stressful times. And finally, other common rashes that you might encounter with displaced people. So dermatology specialty depends on visual and pattern recognition. So I'll be starting with pictures and clinical scenarios before discussing each condition. So let's start with the first case. This is a 30-year-old female who presented with itching at night that started before any skin lesion appeared. Then she started having papules over the wrist and under the breast. And other close contacts were also itching. They tried topical steroids to no avail, and she's carrying her baby in the last picture with the lesions over the soles and over the face. So as you might have guessed, this is a classic case of scabies, and scabies is caused by the ectoparasitic mite. The incubation can be up to a month, and they present with a nocturnal itching and the lesions over the interdigital web spaces and the genitals, but the babies can also have it on the face and on the palms and soles. Finding a burrow on exam is pathognomonic, but it's not always seen. And interestingly, we're seeing more and more the severe form of scabies, which we call the crusted or the Norwegian scabies, probably because we're lacking a lot, we're having delayed diagnosis, and we're having a lot of wrong treatments with steroids prior to presentation. So the risk factors include crowded conditions, the poor hygiene, the poverty, the malnutrition, and the homelessness, all of which are present in our displaced populations. And for the treatment, we usually prescribe the Lindane 1% lotion to be applied overnight on day 1, but they have to repeat the treatment in a week, so on day 8 for any remnant scabies. We're also giving a lot of ivermectin, 0.2 milligrams per kilo, to be repeated also in a week on day 8, and we're combining it with Lindane for the severe cases. Benzyl benzoate, we're finding it irritant and there's more resistance to it. But for infants less than 2 years old and the pregnant ladies, we cannot give Lindane because it's neurotoxic, so we go for sulfur 6% in Vaseline to be applied for 3 consecutive nights and again repeated in a week. Prevention is as important, if not more important, than the treatment. It's very important to treat all of the close contacts. Otherwise, they will recontaminate each other because, as we said, the incubation period is up to 6 weeks. Washing everything in hot water more than 60 degrees. But in our displaced people, if they're not able to wash their clothes and their towels, we can ask them to keep their belongings in a plastic bag sealed for 3 days because the mites cannot live outside of a human host more than 3 days. Aeration of the mattresses in the sun is good, and avoiding skin-to-skin contact until the treatment is complete in a week. Do not forget to ask your patient about the genital area. This is a picture taken from our displaced patients that came and saw us in clinic, and this is typical scabies. So when you have itching, you can see also these lesions over the penis. Now, this is the second case. These are 2 different patients presenting to you with itchy scalp, and you can see the white scales on the hair, but one actually is lice and the other is dandruff or seborrheic dermatitis. So how to know in clinic? Usually the lice are they're nits that are more adherent on the hair shaft, while the dandruff or seborrheic dermatitis are easily dislodged. So lice cause itching and they favor the occipital area, and they can also present over the eyelashes. Risk factors are children from age 4 to 14, the girls because they have long hair, and having a greater number of children in the family and sharing the beds and the pillows. So for the treatment, we give them the anti-lice shampoo for 3 consecutive days, and they repeat it in a week, but we always tell them keep it for 15 minutes so that it has time to act. But more importantly, we tell them manually to try and extract those nits using a metal comb, ideally, good lighting, and when the hair is still wet, from the ends of the hair upwards to the scalp. Now, another thing to do is to simply ask them to get Vaseline ointment if they're not able to buy an anti-lice shampoo, apply it overnight or with a head cap, and then wash it off in the morning. And because it's a thick ointment, it can help suffocate the lice. Ivermectin is also given off-label, but it's double the dose than the scabies. For the prevention here, again, we have to treat everyone in the family. As Dr. Hussein said, lice is very common with our displaced people. They shouldn't be sharing brushes, hats, or even the bed. And we also tell them to use the hot hair dryer for 30 minutes because the heat can help with killing the lice. and washing everything. These are other pictures taken from the displaced patients that are seen in our clinic. So these are siblings presenting with these plaques around the mouth and around the nose. So this is typical bacterial impetigo, most commonly by Staphylococcus aureus, but we also see it with strep. And it's around the mouth, it's peri-orificial, and it leaves this honey-colored crust. And when it's disseminated, we can also have with it lymphadenopathy and fever. The risk factors are similar to the previous risk factors for the conditions of crowded environment. And for the treatment, it's topical antibiotics, but when it's more widespread, when it's more than 3 lesions, when we're having the bullous type of impetigo, or when we're having systemic symptoms with associated fever, this is when we have to go for oral antibiotics for a week. Usually we go for a first-generation cephalosporin such as cephalexin. But if you're suspecting resistance, ideally you take a swab culture, because in case of MRSA, we have to switch to Bactrim or clindamycin or doxycycline. Prevention is similar to the previous slides, so hand hygiene, covering the lesions, and not sharing the personal belongings. This is another picture taken from our clinic. A patient presented with a very painful localized rash over the left arm of 2 days duration. And here the duration or the acuteness of the event is very important because this is typical shingles or herpes zoster. So you don't always see the classic vesicular rash. Sometimes they come late with this crusted presentation. So shingles, as you know, is varicella zoster virus HSV3. It's reactivation. The primary infection is chickenpox. And sometimes they present only with a prodrome of itching or pain over the dermatome before having the vesicles, the crouped vesicles over this area. But when it's multiple dermatomes, then you have to suspect an immunosuppression. The most common location is the trunk, and the post-herpetic neuralgia can last for months. The risk factor are the immunosuppression and the elderly, but in the case of our displaced people, also the physical and the emotional stress can re-trigger and reactivate the zoster virus. For the treatment, if they are able to find Valtrex or valcyclovir, we prefer it for the dosage because it's only 3 times a day compared to acyclovir, which is 5 times a day. They're both given for a week, and we have to start them as soon as possible within 3 days of onset. And for the post-herpetic neuralgia, we can give something like pregabalin or vitamin B supplementation. For the prevention, so the spread is via droplets or direct contact, and it's contagious 2 days before the lesions appear. So we ask them to keep the lesions covered, and they have to stay away as much as possible from pregnant ladies, from elderly, and from immunosuppressed patients. And we can also give a topical antibiotic for a superimposed bacterial infection. Other common viral infections that can easily spread with poor hand hygiene and poor hygiene are the verrucous warts, and also in school kids, these umbilicated pearly lesions are the molluscum by the pox virus. So here again, we can give the acids for both conditions if they're not able to come to clinic. The next case is a patient who presented with a very itchy plaque over the buttocks, and then he tried Dermovate or a topical steroid, which helped with relieving the itching, but did not cure him. It kept on progressing to the inguinal area. So you examine him and you see over the feet the scaling and the wet white macerations between the toe. So this is typical tinea, which we're seeing a lot again. So tinea corporis, pedis, and cruris. But we don't always see the central clearing and this beautiful classic presentation. Sometimes when they're coming with, and they've used already topical steroids, we can get something that we call tinea incognito, and it would look like dermatitis. So if you're suspecting that a patient is not improving on topical steroid for his eczema, think of tinea incognito. So tinea are caused by the dermatophytes, and they cause this pruritic annular plaque with the elevated border. And the risk factors include this household crowding, the hyperhidrosis and occlusive clothing, but also diabetes and having house pets. The treatment is topical versus oral terbinafine. Ideally, usually we use it for 2 weeks to 1 month. But for pregnant ladies, we try to stick to topicals because all of them are category C. For the azoles, the only one that's category B is oral terbinafine. So we try to wait on the topicals until she delivers. For the prevention, we ask them to dry the skin well, wear loose clothing, and very important, not to use over-the-counter creams for fungus because most of them are combinations that might include topical steroids, and this would only increase the resistance in our community. So the next presentation would be someone or a kid who's presenting with an itchy plaque over the scalp, with a bit of scaling and hair loss. So in this case, we have to differentiate between tinea capitis and scalp psoriasis. And tinea capitis would be more itchy, the hairs would be more easily pluckable, and more hair loss, and maybe even associated with lymphadenopathy. So this is again a dermatophyte, and we can see on exam these black dots, which represent the easily pluckable hairs. The risk factors include school-aged kids, but I will talk about the adult presentation in the upcoming slides, but also having animal contact and household crowding. For the treatment, not less than 6 to 8 weeks. Usually we prefer starting with griseofulvin, but oral terbinafine is also an option, and we combine it with ketoconazole shampoo. For the prevention, we again have to treat everyone simultaneously, the close contacts, and we shouldn't be sharing the hairbrushes, the hats, and we have to clean all of their belongings. And always ask them to check their pets as well. If they're shedding hair, then they also should be treated. And if they're presenting with a buggy inflammatory nodule, this is what we call chirion. So this is basically tinea capitis with superimposed bacterial infection. And in this case, it can be associated with fever, lymphadenopathy, and it can leave scarring, permanent scarring. So it's very important to treat with both oral antifungals and oral antibiotics. As for adult tinea capitis, so the presentation is very atypical and variable. It can look like psoriasis, it can look like folliculitis. Keep it in mind because it's more common than you think, and we can see it in postmenopausal women. Now, another condition commonly seen in spring and summer, but weirdly we're seeing it more with our displaced people, is tinea versicolor. And from its name, versicolor means that it can present as hypo or hyperpigmented or even erythematous plaques. So this is an overgrowth of Malassezia fur that's normal on the skin flora and that favors the sebaceous distribution of the upper trunk and the face and scalp. But as I said, the risk factors are summer, humidity, and sweating. So why are we seeing it now in winter with our displaced people? Actually, tinea versicolor has been reported to flare and recur during illnesses and during emotional stress. So this is the case of our patients. For the treatment, it's topical usually, the topical shampoos or the azoles. And if too widespread, we can give a short course of oral azole, but terbinafine does not work. And for the prevention, because it tends to recur, we ask them to keep the shampoo once a week as maintenance. Now, moving on from infectious to inflammatory, common conditions like eczema or atopic dermatitis and psoriasis, they're not contagious, but they do flare with stress and with the cold weather. Now we're coming to winter and the dry weather, and they both require emollients and they would both improve on topical steroids. What are the key differences? In atopic dermatitis, it's associated with dry skin, with atopy history, with more itching, and it's more localized over the flexural areas. While in psoriasis, there are silvery scales that are thicker over the extensor surfaces, and we also have involvement of the scalp, of the nail, and of the joint, and they do improve with sun exposure. So why differentiate between the two if both of them are improving on topical steroid? If it's more diffuse or severe with atopic dermatitis, sometimes we might require a short course of oral steroids. However, this is an absolute no for the psoriasis. In fact, with oral steroids or systemic steroids, psoriasis can get worse and progress to generalized pustular form. So for psoriasis, when it's severe, we go for methotrexate and cyclosporin since the biologics are not readily available. And finally, a few conditions to keep in mind in the case of our displaced people. Dermatitis neglecta, this comes with poor hygiene. It's a progressive accumulation of the sebum, the sweat, the keratin, and the debris, and they form these hyperpigmented brown plaques that would not be easily removed in shower. And the diagnostic test, but also the treatment, is an alcohol swab sign, which is 70% isopropyl alcohol. In clinic, you can just rub it off, and this would give you the diagnosis, and you can reassure the patient. And finally, nutritional deficiencies to keep in mind. So as you know, malnutrition can affect the skin, the hair, the nails. Most commonly, we would see this angular cheilitis, which is from vitamin B deficiencies. In the case of vitamin B12, we can also see glossitis. But also, remember, zinc deficiency can come with a triad of periorificial dermatitis, alopecia, as well as diarrhea. It can be genetic, but we also see it as acquired in alcoholics, in anorexic patients, and in malnutrition in the case of our displaced people. So we've covered a range of dermatological conditions commonly encountered in displaced people, from infectious to non-infectious diseases. While the focus was on diagnosis and treatment, prevention through the basic hygiene and early intervention is crucial. The inappropriate use of topical steroids continues to complicate many cases that we see. So education about this remains essential. Looking ahead, we hope that these medical challenges become memories of the past, as our ultimate goal is to see our displaced people return home. Thank you for listening.